So my job here, it was interesting. I was asked to look at a specific new therapy for lupus, and I'll talk about that in a moment. But first, let me begin by saying that the fact that we can talk about new therapies in lupus is so exciting. It's such a new area that we have so many new agents that are in line for treatment with lupus. So there are a number of agents now. It's interesting. The agents are being investigated. Some are already available, and but being available doesn't mean that necessarily that they're available to all patients, because the new medications are expensive, and not everybody will have access to these medications. So if I could just, as an overview, the newer medications, I won't talk about steroids or antimalarials or the classic immunosuppressives, but the newer medications like belimumab has been around for 11 or 12 years. And then the newer ones that have been recently approved in many countries, such as anifrolumab and voclosporin, will certainly be making impact over the next number of years, I'm sure. Now, there are a lot of new medications in in process at the present time. So the first ones that I want to just mention briefly are building on the experience with belimumab. Remember, belimumab was an anti-B cell drug, and sort of eliminating or dealing with the B cell stimulating factors, and the new anti B cell drugs, namely telitacicept, that I want to talk to you about for a moment, and Ianalumab. Both of these are not only anti-BLyS like belimumab, but are anti-BLyS and anti-APRIL, which I'll talk about in a moment, and maybe even more potent than belimumab itself. That is their hope, obviously. And then there are a whole bunch of new drugs, especially the JAK kinase inhibitors, some of which are really very close and are in phase 3 studies. And so the fact that we're able to talk about these drugs that are actually close, leaving out the drugs that aren't close, like the CAR T cell and the anti-inflammasome drugs, etc. But these drugs that I mentioned here are close, and so I look forward to the day that we have all of these choices for treatment with lupus. So let's talk for a moment about building on the belimumab story, which was an anti-BLyS. So could I have the next slide, please? Do you have that handy? Good. So in terms of the B cell growth factors, there are a number, but the two that we've heard about a lot are the anti-BLyS and anti-APRIL, and then the anti-TACIs also, but the anti-BLyS and anti-APRIL. And as you remember, the anti-BLyS drug, belimumab, worked specifically on BLyS, although it may have had some effect on the other receptors for B cell growth and development. But the new drug, telitacicept, definitely is anti-BLyS and anti-APRIL. And so in theory, this could even be more potent than the anti-BLyS by itself in terms of inhibiting B cell growth, survival, etc. So next slide. So we learned about this in its furthest development at EULAR this year, where telitacicept was shown, was presented as a new, very potent medication for lupus. Now, I want you to hold your hats here, because this will surprise you, as it already has, I'm sure, as much as it surprised me. Next slide. So they used a large number of, this study was done in China entirely. The phase 2 and the phase 3 were both done in China. There were 335 patients, so there were 167 patients, 168 patients in the drug and the placebo group. Telitacicept is given as a subcutaneous injection once a week, And then the two groups that were evaluated were similar to each other. And you see here, this is the report of 71% of the patients who completed the entire 52 weeks of the study. Their primary endpoint was the SRI-4, and it was significantly greater in the telitacicept group than in the placebo group. And so, next slide. This was so dramatic. Here you can see a number of very important things. Number one, the telitacicept group had a much greater response to SRI-4. The response began here in some significant degree by 4 weeks, and then rose rapidly and stayed the entire 52 weeks. So the difference here, could you go back one slide, please? Oh, no, forward then, sorry. Forward and one more, yeah. So the difference here was very dramatic. So there was between the telitacicept group and the placebo group, there was something like a 60% difference in response to SRI-4. Now, if you will remember, belimumab was approved because it had 11% difference between the outcome measure between placebo and drug. And here we're talking infinitely higher than that. This is a very dramatic effect. And you can see here that there were some side effects that in the two. These were the side effects that we expect in all of these, like mild and in some more severe infections. There were no deaths. The rates of infections were similar between the telitacicept and the placebo groups. The most common adverse events were the ones we expect, like upper respiratory infections, decreased IgG, which may be one of the reasons for the infection, and then the injection site reactions and urinary tract infections. These are the things that we see in all studies. Next slide. So this drug, phase 3 drug, met its primary endpoint. It was well tolerated in patients with lupus. Next slide. Oh, that's it. So my question, what do we think of this? This was so dramatically different from the response rates that we've had in other drugs. Is this really the drug? Is there an ethnicity issue here? These studies were all done in China, and would they have the same influence in Caucasian patients or in African descent patients as they do in Chinese patients? So it's clear that even though this is a phase 3 study, and I believe that this drug is actually licensed in China, what more needs to be done to make this drug available and found to be effective in other parts of the world? So there's your first example then of one of the new drugs that seems to have a dramatic effect, has a very good rationale for its use in terms of its antagonism to B-cell growth factors and inhibiting B-cell growth and development, and has very few side effects. So I'd be interested to your thoughts. Is it important that all of these studies were done in China only? Does anybody else have any other comments on this or any experience with this agent? I'd be very interested to hear that. Dr. Wade, have you heard of this drug?
We don't have these drugs in Taiwan, but I know three of my friends in China are using it since 2021, approved in China.
Right.
And I also know the PI, Professor Zhang, who is the corresponding author of the phase 3 trial, Zhang Fengchun, quite well. And I spoke to him for many times. And I think most of the rheumatologists are using these drugs in lupus right now. And it seems that the real world efficacy is equivalent to the RCT. So I would say, I don't have personal experience, but for communication, I would say it's very useful right now in the real world in China.
Yeah. Well, that's interesting that that the phase 3 is now translating into real world efficacy as well. This is by word of mouth. Obviously, we haven't seen any studies along that area yet, but it's a very exciting finding. You know, that we had this great difference between response to the classic responder index between belimumab and this drug. Any other comments on this? Betty, what do you think?
Well, I think it's great. And I think that, you know, there was a trial of another agent that did just this, a Tasep, a long time ago that was
Right.
stopped because of, I guess, an episode of sepsis.
Right.
And, you know, in retrospect, that may have been stopped prematurely. But this, I think one of the reasons this is more effective than belimumab is that this blocks plasma cell differentiation, both through a germinal center route and through an extrafollicular pathway. And one of the things I think is clear in lupus patients is they just make too many plasma cells. And if you can block that, you have a chance of reducing lots of the autoantibodies. So it's, I think, not so surprising that this is more effective than belimumab. And I think it's tremendously encouraging because if it has anywhere near the safety profile of belimumab, it will be a great drug.
Right. And you know, another one of the anti-BLyS, anti-APRIL drugs, Ianalumab, is actually had a very similar positive phase 2 study and is now in phase 3 study. So that that mechanism seems to be a very promising mechanism. Manuel, you had a comment?
Thank you. Well, I think it's important to have trials in another part of the world. I mean, I think ethnicity is going to impact this drug and other drugs. So I think we need more information about the drug. But the drug seems to be interesting because it works not only in SLE but also in IgA nephropathy. So it seems that it's a promising drug, and probably I think one of the effects of a Chinese biologic is going to be that I expect that to be less expensive. So for our country, probably we are going to have more access to this drug, I think, or at least I hope, because I think the owner of the drug is the government. So the cost is going to be at least a bit cheaper, I hope.
Right.
And I would say that I think this is unlikely. Oh, well, as you say, there's already another clinical trial going on showing efficacy, but it's unlikely this is going to be restricted to China. I think we can be very enthusiastic about this drug.
Yeah, I agree. But in order to convince the FDA and the EMA, I'm sure they're going to have to be studies in other populations.
I'm sure too, and that's good.
Yeah.
I agree that this is really very promising new biological therapy for lupus. When I have to tell you that when I am informed on the mechanism of action of a new drug, I'm always a little bit skeptical because there are so many pathways involved in the production of the disease in lupus that maybe you can have a very good drug blocking one pathway, but then another pathway will go up and then manifestations probably will reappear. But in this case, that we are talking probably on the combination of blocking two receptors that are clearly involved in the pathogenesis of B-cell involvement, including plasma cells, both April and BLyS, and we have previous experience, good experience with blocking each one of these receptors separately. I think that really the background, the rationale for the effect was clearly very good. And then is the results of a phase 3 trial. And a phase 3 trial, I think these results are the most impressive that we have seen in any phase 3. We have seen good results in phase 2 that then in phase 3 were not so good. But this is a phase 3, so this is really excellent. And if we have this, let's say in some way, confidential or very new information on real life in China nowadays, that it works in a similar way that in these phase 3 trials, this is really excellent, marvelous, and let's hope that this is confirmed in other trials in other parts of the world, because certainly it is absolutely essential to have the reproduction of these trials in other parts of the world. And let's hope that this will be a very, very good drug for our lupus patients.
Ricardo, I want to make one other point, and it relates to what you started your discussion with, the multiple approaches, mechanisms in lupus. The whole discussion now of whether we should be using combination therapy up front, rather than sequential therapy over time, when one fails, go to another one. And EULAR took one major step. I was nervous, but commend them. If you look at the treatment profiles for lupus in the EULAR recommendations, they show that you can start belimumab or anifrolumab at day 1. There's no need to go through all those others, and using a few together are acceptable, even though there's really no evidence for this. And I've been haranguing pharma to do that study now. Let's do combination drug up front at day 1 rather than waiting until a later date. So that's maybe the point for discussion in the future. What is the new treatment paradigm? Is it combination up front? Is it still sequential? And which drugs can you use up front, etc. So that's sort of for another day, and then we can discuss whether we should start telitacicept up front along with something else or leave it till later.
This was certainly the most disruptive recommendation in the 2023 EULAR recommendations. Actually, we stress that any patient requiring something else than hydroxychloroquine plus equal or less than 5 milligrams prednisone, you can consider any of these drugs, the classic immunosuppressive drugs, the new biological therapies, combining both. So this is really probably the important thing. Try to start as soon as possible with more effective therapy, not step by step. Probably start as soon as possible. This is just based on what has been done in other diseases, in other autoimmune diseases, for instance, in rheumatoid arthritis. Certainly in lupus, we have not yet any trial that demonstrates this, but probably we can expect similar effects that happen in other autoimmune diseases.